let's kickstart this instruction course with a brief introduction on chemical injuries. I completed my fellowship recently from Prasada Institute and now I'm currently practicing in Delhi. And I'll be presenting a lot of photographs during my presentation which I came across when I was working at Delhi. So, chemical injuries constitute true ocular emergencies and they're very important because about 7 to 10% of all the ocular injuries that we see in our practice. And most of these tend to be accidental in nature and occur at work. And criminal assaults formulate 10% of these cases. What is important for us to understand is that they affect the young male population, and these are the people who are economically productive. So it doesn't just impact an individual, it impacts the family as well as the society as a whole. And a significant number of them tend to be bilateral and result in cosmetic as well as visual disability. So the alkali burns are way more common than the acid, especially in our country when tuna injury is a huge hassle. So this lime or tuna comes in these plastic packets, and lots of times kids are sent to the local vendor to get it from there, and when they are coming back with the packet they tend to play with it and it bursts and affects their eyes. So this is a very important mode of injury in our country. So what is important to understand about lime is that it tends to get retained in the upper corneas. And there is prolonged toxicity because of the retained particulate matter. The other very important alkali is ammonia because it combines with water to form these fumes which have a very rapid penetration and can cause a lot of damage. Amongst the acids, the most dangerous is the hydrofluoric acid. It has a very small molecule and therefore it can penetrate very easily and can produce an injury almost as severe as an alkali burn. The more common acids that we come across are the sulfuric acid as well as sulfurous acids. So sulfuric acid is present in batteries, and if the injury is associated with a battery blast, then they tend to have associated intraocular foreign bodies which can further complicate the management of such cases. So the severity is essentially related to the agent that causes the injury, the surface area of contact, and how deep is actually the chemical penetrating inside the eye. So what happens in alkali burns essentially is that the hydroxyl ion causes saponification of the free fatty acids in the cell membranes, and the cation rapidly penetrates inside the eye. So in the cornea, it reacts with the carboxyl groups of the stromal collagens as well as the glycosaminoglycans. This leads to loss of clarity of the stroma because of the hydration, and also distortion of the trabecular meshwork because of hydration of the collagen fibers, and causes the early rise in intraocular pressure. There is also an ongoing inflammation, and therefore this releases the prostaglandins responsible for prolonged rise in the pressure inside the eye. Now when they penetrate the anterior chamber, there is increase in pH which damages the ciliary body epithelium. This leads to decreased production of the ascorbate, and as we all know, ascorbate is essential for collagen synthesis as well as stromal repair. So these processes can get affected and they can be ulceration, and if the pH levels are prolonged for a very long time, it can cause irreversible intraocular damage and can eventually lead to phthisis bulbi. So what happens in acids is that the anion actually causes protein precipitation and denaturation in the corneal epithelium and the superficial stroma. This acts as a barrier to further penetration and therefore limits further intraocular injury. This coagulation of proteins gives rise to the classical ground glass appearance. So basically there's a process going on of collagen breakdown, inflammation and repair. So what do we do when we come across this case in the clinic? First dictum of chemical injury is treat first and examine later. So this is very important because the severity of injury is directly proportional to how long the agent is in contact with the ocular surface. So you should do a quick examination, rule out open globe injury, and then take the patient out for copious amount of irrigation, at least 1 to 2 liters. If you have a litmus paper, it's a good idea to test the pH. And it is essential to avert the upper lid and look for any retained particulate matter, especially lime particles. So how do we classify such cases? Initially we had the Roper Hall classification, which grades chemical injuries into 4 different grades. This classification is based on the corneal clarity and the amount of limbal ischemia. Now the problem with this classification was that it doesn't cover the extent of conjunctival damage, which is very important for prognostication of these cases, as well as it groups all the severe injuries together in grade 4. So therefore leading to inconsistent results. So in 2001, Professor Dua published this paper, and what he essentially did was that he classified severe injuries into 3 different categories, and also took into the consideration the percentage of bulbar conjunctival involvement. And if you notice, the term limbal involvement is used instead of limbal ischemia. So essentially, we should stain the ocular surface and see wherever there is a stain positive, and those are the areas we should consider as limbal involvement. So I'm going to show you some pictures of such injuries. So this is grade 2 Dua's classification. As you can see, it's involving less than 3 clock hours and minimal conjunctival involvement. And this is a more severe grade 3 injury where it involves nearly 5 clock hours and more extensive conjunctival involvement. So it's absolutely essential to stain and examine these cases, and not just the cornea, also the limbus and the conjunctival epithelium, and to monitor these cases with fluorescent stain. This is an example of a more severe grade 4 injury. As you can see, the palisades are intact only superiorly, and the rest of the conjunctiva was more than half involved. Then this is a more severe case where actually the palisades look intact, but when you stain the ocular surface, you see that conjunctiva is completely blanched and it takes up stain. The whole of bulbar conjunctiva as well as the corneal epithelium was completely absent in this case. It is a very severe grade of chemical injury. So based on the grade of chemical injuries, we have the healing pattern, how the tissue is going to respond and to the chemical injury. The type 1 healing pattern is normal epithelial recovery, where restoration of an intact and phenotypically normal corneal epithelial surface takes place. So these cases have the best prognosis. Then we have the type 2 healing pattern or the delayed differentiation, where there is some loss of limbal stem cells and there are areas of focal conjunctivalization. And if there is preservation of proximal conjunctival epithelium, but there is loss of the corneal epithelial cells as well as the limbal stem cells, then the conjunctiva grows over the cornea and leads to formation of a fibrovascular pannus. In cases where even the proximal conjunctival cells don't manage to survive, then we don't have enough epithelium to cover the surface, and this leads to ultimate sterile ulceration, which can secondarily get infected and complicate these cases. Apart from this, we also have additional ocular surface abnormalities which need to be taken care of because of the ongoing inflammation and fibrosis. There can be formation of symblepharon and adnexal problems, again because of fibrosis like cicatricial entropion or trichiasis, and the underlying corneal scarring. So characteristically, we have 4 distinct phases which have been described in the literature. In the immediate phase, it is imperative to decide what grade of injury it is and to go ahead and do a copious amount of irrigation. Then we have the acute phase in which the epithelial recovery starts, and the early repair phase, and then the late repair phase after 21 days where we take a definitive decision regarding the further management options. So management of all these cases will be taken care of in the subsequent talks. And I'd like to acknowledge Every Prasad Institute for the photographs, and thank you all for your patient hearing.